So we'll move to the next topic. Before that, we have a small video for 35 seconds to run it. And then after that, I'll announce the chairpersons. Monica, can you run the videos a little bit, 35 seconds? Thank you. And this was needed. Now we are moving to a very, very interesting sessions, medical management of heart failure, HEPREP or HEPEP. So in this connection, I would invite the chairperson, Dr. Dayasagar Rao from Hyderabad and Dr. G. Arkani from Mumbai to invite, I'm inviting both of them over to the chairperson to conduct the session, please.
Brian is Dr. J.S. Wonder. He is a cardiologist from Ludhiana, has a lot of experience. He's going to tell us about role of SGLT2 inhibitors in heart failure. Dr. Wonder, please go ahead.
We just heard some very elaborate discussion on how to diagnose heart failure in various circumstances. So I'm going to talk about one of the major changes that has happened in my clinical practice, at least in terms of management of heart failure. And in the next 12 or 15 minutes that I have, I will dwell upon the reasons why this change has occurred. In fact, I was just going through the 2018 Indian guidelines by the Heart Failure Association of India. And at that time, we did not even consider actually SGLT2 inhibitors, because this data, what we are now going to show you, which has altered our practices to a very, very large extent, is because of some of the very recent studies that have been published in the last 4 or 5 years. And it's a pleasure and an honor for me to present it at this International Heart Failure Summit. This is actually well familiar with all of you. We were discussing some pitfalls in ejection fraction. It was interesting listening to Chandrasekhar. He says 9% differences, interpersonal person differences, or same individual doing it 2 times could be there in ejection fraction. But we take it with a pinch of salt, and we do realize that there is a great merit actually in distinguishing heart failure into heart failure with reduced ejection fraction, heart failure with preserved and the mid-range, which you're all very familiar with, and which does actually make a huge difference in terms of how aggressive we are with the guideline-directed medical therapy that we pursue. But at the same time, I would say SGLT2 inhibitors, when it comes to using these agents, that issue becomes a little fuzzy because they have a role in all 3 situations. We know Indian heart failure is different. Our patients are 10 years younger. We have a greater male preponderance, and coronary artery disease patients are more with us. 1-year mortality is around 31%. And a 3-year mortality of Indian heart failure patients is almost like the 5-year mortality in Western countries. And we did show in the Asian heart failure trial that guideline-directed medical therapy actually was not so aggressively pursued in terms of reaching the right dosages, if not starting the 3 class of drugs. We also did show in the Asian heart failure study that you all know actually this, that the pattern of obesity amongst Indians is very different. We have a central type of obesity. And in this beautiful slide, we showed that it's the lean fat individual which has much higher number of primary events, that is 22%, as compared to the routine obese who has a high BMI and a high waist-hip ratio, 15%, and obese thin, that is no central but otherwise obese, 11%. So it does make a difference as to what kind of a individual or which race individual has heart failure, because metabolically we are very different. And these agents, we know they have a lot of metabolic effects because they act on the proximal tubular cells, where they affect the sodium and the glucose discharges. And so the sodium chloride delivery to the macula densa is increased, uric acid excretion is increased, which results in increased glucoseuria, increased natriuresis. This helps in diabetes, this helps in heart failure. And basically it is the same actually mechanism which results in reduction in glucose, body weight, blood pressure is reduced, uric acid comes down, and there is decreased glomerular hyperfiltration. So it is essentially this increased urinary sodium and glucose excretion which causes the increased hematocrit, the weight loss, and the improved ventricular load conditions that we see with the use of the SGLT2 inhibitors in heart failure. We all know these drugs were initially tried for diabetes, but today the nephrologist feels it belongs to them, and all of us cardiologists feel the drug has a greater potential and greater usage amongst us. So just like with the statins, we are looking at some of the pleiotropic effects that the SGLT2 inhibitors have, and we have come to realize that there are many additional mechanisms by which these drugs are beneficial. There is altered adipokine regulation, there is autophagy induction, and which results in improved cardiac hemostasis, and cardiac myocardial energetics are improved. So there are very many mechanisms because of this primary effect which they have on the primary convoluted tubule, because of which the SGLT2 inhibitors showed actually in these many, in fact, 4 of these large initial trials in which they were used for patients with diabetes, whether it is empagliflozin in the EMPA-REG, it was dapagliflozin in the DECLARE TIMI 58, it was canagliflozin in the CANVAS, or ertugliflozin in the VERTIS trial. In all these studies, there is some cheating happening with me. 9 minutes it is showing, but anyhow, I'll handle it with this. So all these initial trials which were done for diabetic patients, they all showed actually that the CV mortality is reduced significantly. And also the heart failure actually, look at the hazards ratio. They are looking so similar with all these. And so we realized that this is a class agent, and that paved the way for use of the SGLT2 inhibitors, dapagliflozin in the DAPA-HF, and the Emperor-reduced trial, empagliflozin. Large studies see about 4,500 patients and about 3,000 patients. So very large studies, whether it was the DAPA-HF or the Emperor, and almost very similar hazards ratio of 0.74 and 0.75. So these big studies proved actually a couple of years back that when we use SGLT inhibitors in patients with reduced ejection fraction, we impact mortality to a very significant extent. And so, in fact, one of my mentors, Dr. Inder Anand, was, Dr. Chopra is there. Many Indians contributed to the DAPA-HF trial. And you can see the number needed to be treated was 21 for reducing one of the primary events, whether it is CV death, heart failure, hospitalization, or urgent heart failure visit. And so SGLT2 inhibitor became the 5th arm along with the ACE inhibitors arms, the RAS blocker, beta blocker, aldosterone antagonist, and ARNI. Actually, these should not be separate arms because you either use ARNI or you will use a ACE or an R, one of the 3. And of course, so one can say it's a 4th arm or a 5th pillar, whatever you want to call it. But certainly dapagliflozin became one of the pillars because we realized that if we use none of these agents, the 2-year mortality is 35%. If we use ARNIs, it comes down to 25%. If we add a beta blocker, it comes down to 16%. If we add an MRI, it comes down to 11%. And if we add SGLT2 inhibitor, it comes down. So there was, in fact, a beautiful paper by Milton Packer and Dr. Anand, which showed that if there is a 55-year individual with a reduced ejection fraction and you use all these 4 class of agents, you will be reducing their mortality. You will be increasing their longevity of life by 7 to 8 years. And so after having had success in heart failure with reduced ejection fraction, we thought, let's look at the patients with mid-range and preserved ejection fraction. And so these two big trials came up, which have been released in the last 1 year only. The Emperor Preserved, which looked at empagliflozin in one thing very peculiar about the SGLT2 inhibitors as compared to beta blockers, MRAs, or more often the RAS blockers, is that it's a fixed dose that you use. There is no escalating dose which has to be used with some of these agents. And the Emperor Preserved did show us that although the amount of benefits that you achieve with SGLT2 inhibitors in mid-range or preserved ejection fraction are less than in patients with reduced ejection fraction, but still the number needed to be treated is 31. And there is a significant reduction in primary events of CV deaths or heart failure admissions. And so there was a significant benefit, a greater benefit, which was shown in the mid-range ejection fraction patients. And this was actually an additional benefit, which showed that although there is an initial decline in GFR whenever we use these SGLT2 inhibitors, just as we were so familiar with the RAS blockers, but look at this. The rate of decline of GFR in the subgroup, which was on empagliflozin, was significantly less than in those who were on placebo. And so there are additional renal benefits that your patients get besides reduction in heart failure hospitalization or in overall mortality. And after success with empagliflozin, we wanted to look at the DAPA. How does it fare in patients with mid-range or preserved ejection fraction? And the DELIVER trial actually was released this May 5th. And look at the heading. The breaking news says DELIVER trial scores a win for dapagliflozin in heart failure with preserved ejection fraction. And so from an era in 2021, when the European guidelines actually showed us that diuretics in heart failure with mid-range ejection fraction are a class 1 indication, ACE inhibitor, ARB, beta blocker, MRA, sacubitril, and even the SGLT2 inhibitors all fell into the 2B category. But I'll just show you the change that has happened, because we have realized that if you have a total actually analysis of all the trials published till now, in terms of hospitalization for heart failure, the hazards ratio is 0.68, whether the patient is a diabetic or a non-diabetic. So we really don't try to distinguish actually whether even the CV death, the hazards ratio is 0.8, whether your patient is diabetic or a non-diabetic. And so in the 2022 AHA-ACC guidelines, now these SGLT2 inhibitors are actually first-line agents along with the other agents in patients who have symptomatic heart failure, and even in patients with stage A, where your patient has diabetes, you would like to use SGLT2 inhibitors. But in patients with stage C and D heart failure, today SGLT2 inhibitors are a class 1 indication, along with the other agents that I just discussed, the RAS blockers, the MRAs, and the beta blockers. So that is essentially the position where the SGLT2 inhibitors are today in these people. Even in the mid-range, actually, look at these latest guidelines released last month, which show diuretics, of course, class 1, but SGLT2 inhibitors are 2A in the mid-range, whereas the ACE, ARNIs, the MRAs, and the beta blockers, we know benefits are less in the mid-range ejection fraction patients. Look at the preserved, again, diuretics, yes, of course, class 1 indication. SGLT2 inhibitors, thanks to some of these large trials, are 2A, so you would like to use these agents in most of your patients, whereas ARNI, MRAs, and ARBs are still class 2B. So just at the cost of repetition, in patients with symptomatic chronic heart failure reduced ejection fraction, SGLT2s are a class 1A indication, and there should be no patient actually whom you do not put today on SGLT2 inhibitors. All these fears of side effects and all we know. Yes, sick day withdrawal, pre-operative patients going for surgery withdrawal of SGLT2 inhibitors, hygiene of the external genitalia, these are important precautions which we take. But these should not dissuade us from using them extensively. Even in mid-range, they are class 2A, and in preserved ejection fraction, again, they are class 2A indication. So I would end here by actually this sharing this slide with you. In stage A, if your patient is a diabetic, we have to use the SGLT2 inhibitors. Stage B, again, if your patient is a diabetic, yes, you will use. But stage C or D, whether even D now, people are discussing before discharge actually in your patients who are admitted with heart failure. Some people are saying start SGLT2 inhibitors even before beta blockers, where others say, but leave that controversy. What we today advocate is pre-discharge, your patients should be put, once you have stabilized your patients with heart failure, whether it is stage C or stage D also, you need to give them the benefits of a RAS blocker, beta blocker, and SGLT2 inhibitors. So essentially, that's the fourth pillar that we have. And we cannot make a stronger argument than what we have just done regarding the use of SGLT2 inhibitors. Luckily, the cost of SGLT2 inhibitors has also come down in the last couple of months. So I would end here by sharing with you that one would advocate the use of SGLT inhibitors, 2 inhibitors, certainly in all patients with reduced ejection fraction. And also today, it's a class 2A indication when we look at mid-range and preserved ejection fraction patients with heart failure. Thank you.
Thank you, Dr. Wander. It's an excellent talk, giving a good, nice sort of an overview in whatever time that is possible.